Good afternoon everyone. I am going to present my paper on effect of energy level in ND-YAG laser capsulotomy on intraocular pressure and macular thickness. Conflict of interest is nil and financial support is none. In posterior capsular opacification, visual acuity and contrast sensitivity are impaired and fundus imaging becomes difficult. The first line treatment option is posterior capsulotomy performed with neodymium yttrium aluminum garnet laser. The advantage of this procedure includes the fact that it takes a short time, non-invasive and can be done under outpatient setup. Complications following ND-YAG laser procedure detected by routine examination include intraocular lens injury, iritis, vitreitis, cystoid macular edema, changes in refraction and intraocular pressure, and changes in central macular thickness detected by OCT. The aim of this study was to evaluate the effects of varying energy levels used during ND-YAG laser capsulotomy on intraocular pressure, macular thickness, and to identify optimal laser parameters to minimize adverse effects while ensuring effective treatments. This study was a prospective observational study conducted among 50 patients in a 6-month period at a tertiary eye care center focused on evaluating the effects of ND-YAG laser capsulotomy on intraocular pressure and central macular thickness in patients with PCO after cataract surgery. Inclusion criteria were age 50 to 80 years, diagnosed with posterior capsular opacity causing visual impairment, and history of uncomplicated cataract surgery at least 6 months prior. Any patients having history of glaucoma, retinal pathology or recent ocular surgery or other ocular conditions affecting intraocular pressure or macular thickness were excluded from my study. All the procedures were performed by single experienced ophthalmologist and the laser settings were ranged from 1 to 2 millijoules per shot and the energy level adjusted according to the severity of the PCO and number of laser shots tailored according to the area of PCO. Total energy level was calculated as energy per shot multiplied by number of shots. The pre-procedure baseline measurements of IOP and CMT was done using Goldman apprenticing tonometry and optical coherence tomography, and the post-procedure measurement was taken at day 1, after 1 week and after 1 month. Initial analysis of IOP and CMT changes over time was done, then the sub-analysis based on energy level to identify the potential thresholds was done. With respect to the potential threshold, that is 16 millijoules, the patients were divided into group A and group B. Now, coming to the results, the first plot demonstrates the relationship between different energy level and the corresponding changes in IOP at post-procedure day 1. The red dashed line marks the 16 millijoule threshold, indicating a sharp increase in IOP changes beyond this energy level. Now, this graph shows how CMT changes at post-procedure day 1 corresponds with increasing energy level with a noticeable jump starting at 14 to 17 millijoule range. The red dashed line again indicates the 16 millijoule threshold where significant CMT changes were observed. Now the third graph shows the IOP changes for group A, that is less than 16 millijoule energy level patient, and group B across different time points. Group B exhibited a significant spike in IOP at day 1 which gradually returned closer to baseline by 1 month, while Group A showed minimal changes. Now this graph illustrates the changes in CMT for Group A and Group B over time. Group B experienced a significant increase in CMT at day 1 which decreased but remained elevated at 1 month, whereas Group A showed negligible changes. My study findings are that patients treated with energy levels above 60 experienced significant initial increase in IOP and central macular thickness, normalizing to baseline within a month. Lower energy levels showed minimal changes, and other studies like Parazuli et al., Rota et al., and Karahan et al. Showed the similar findings in their studies. Now coming to the conclusion, tailoring ND-YAG laser energy levels is crucial for managing PCO while minimizing adverse effects on IOP and macular thickness. Further studies to optimize the energy settings for different patients' profiles are highly needed. Thank you.
So as per your study, what is the cutoff level above which the IOP is increasing, or say your CMT has increased?
After 15 to 17 millijoules, if we go above that, then there is a sharp rise in the both IOP and the central macular thickness.
So then again does it come back to normal or?
After 1 month, it comes to the pre-procedure level.
Okay.
So what, you have done this study, but what recommendation then you would like to give to the audience?
We have to regularly check post-procedure the IOP and the macular thickness level, and we have to tailor the anti-glaucoma or the other drugs according to that.
Other thing is, if you are feeling that you have used too much of energy, do it as a two-step yak capsulotomy. So if you have used too much energy, call the patient back. Don't keep on using energy. If the patient is a high risk for glaucoma or a steroid responder, then the IOP will rise even further. So you can always aim for a two-step yak capsulotomy.